So thank you very much. So I'm amazed by the turnout today, and we're here today wearing red to raise awareness to the #1 killer of women in the world, which is cardiovascular disease. And I hope that I can teach you a couple of things today that you're able to then share with your friends, family, colleagues, so we can really raise awareness and hopefully save a woman's life with some of this information. So I'll be talking to you today about heart attacks in women, how they may not be exactly the heart attack that we learned about in school or we saw on TV. And I'll show you some good examples. And I have no disclosures for this talk. As I mentioned earlier, cardiovascular diseases, which are the diseases of the heart, the blood vessels, and includes stroke as well, they are the #1 killers of women in the world. It accounts for 1 out of 3 female deaths. Collectively, these cardiovascular diseases kill 4 to 5 times more women than breast cancer does, and about 2 times more women than all cancers combined. So it certainly is the biggest health threat and life threat for a woman, and this is again why we're here today, raising awareness and learning more things so we can protect ourselves and protect our loved ones. One of the issues when it comes to heart attack, though, and again, I'm going to focus on coronary artery disease today. And every time I say coronary artery disease, I'm going to be talking about diseases of the blood vessels that bring blood flow to the heart. Those are the coronary arteries. So when it comes to coronary artery disease, as in cardiology, we always say that time is muscle. Muscle being the heart muscle. And the fastest you can come to medical attention and the fastest you can be treated, the more likely you are to save your heart muscle and avoid some of the short and long-term complications from a heart attack. Unfortunately, as you can see this here in this fact from the Heart and Stroke report from a couple of years ago, early heart attack signs can be missed in up to 78% of women. And this is why we keep saying that women can be a little bit different than men. So let's dive into this a little bit more. One of the reasons why we can miss heart attack signs, and when I say we, I say we as a person, as a woman, and also as healthcare providers, is because when I say the words heart attack, this is the typical picture that most people make in their minds. It's usually an older man, with chest clutching pain, just like you've seen in the movies. We call it a Hollywood heart attack, Hollywood symptoms. And so if this person walks into the emergency room, there will be no question what's going on. They don't even have to say a word, right? They'll be triaged straight to the heart attack pathway. They will have an ECG and blood tests and even cath lab quickly if they need to. The issue is that we have all created this intrinsic bias and we don't perceive heart attacks to be a disease of women. So what we learn in our textbook is very much what's depicted here. When we go to medical school, nursing school, or any healthcare provider, this is what we learn in our books, that a heart attack symptoms, it's usually presented in men. It's usually presented as a heaviness behind the breastbone or the sternum that may go up to the jaw or to the left arm, and usually brought on by exertion and usually relieved by stress on nitroglycerin. So if anybody comes to the emergency department or to a doctor reporting this, there will be no question what's going on. Anybody can recognize this. What happens in real life, however, can be different. Not always will it be different, but it can be. For example, the chest pain, instead of this pressure or heaviness feeling, may be a burning or sharp or dull feeling. And some women, lots of women I've heard using the term indigestion to describe their pain. Not because they really think it's indigestion, but sometimes because that's the best term that they can come up with to associate the symptoms that they're feeling in there. Sometimes the pain can be just here on the top of the belly, we call the epigastric pain, or sometimes just in the neck or just in the arms. As an anecdote, just about a year and a half ago, I had a patient referred to me in clinic because she had a heart attack. And what happened is the previous Christmas, she had a heart attack, and her symptoms were mostly in her neck. So she went to Google. I shouldn't say that. I should say a search engine. She went to a search engine, and the search engine said that she was having Hodgkin's lymphoma, because sometimes lymphoma can, present in the thymus and in the upper mediastinum. And so she stayed home. So she did not go to the doctor. So by the time everything was discovered, she already had heart failure because of the big heart attack, and she was referred to me. So it can happen just in the jaw or the neck or in the arms. And we also learn, as I mentioned above, that usually the pain is brought on by exertion, but what we see not uncommonly is that the pain can indeed occur as a result of emotional stress or anxiety, or sometimes for no rhyme or reason. And a few people can have just shortness of breath, just nausea, or just exertion without chest pain as well. So some of the things to keep in mind. And some of these symptoms, I wanted to show you this infographic because we have really good infographics on our website, yourheart.ca. So if you go there, you can find some of these common symptoms of heart attack and some of the uncommon symptoms of heart attack, as I mentioned earlier, for you to be familiar with. Now, because of these textbook descriptions, what I think medicine eventually evolved to describe was typical and atypical when it comes to presentation for heart disease. And very often, as a healthcare provider, I'm hearing people say, oh, women have atypical symptoms for heart disease. Women are atypical. And this is really a really bad term. I urge you not to ever use it again if you have used it, and I'll show you why we shouldn't be using this. So precisely because men tend to be recognized more readily because of the symptoms they present, they say usually men typically have typical symptoms. And females may not be just like the textbook, but so they are atypical. Do not use that term again. I will show you why that is bad. This is bad, and it really perpetuates stereotypes, right? And at the end of the day, you don't want to, it's not only stereotypes, but also bias, right? So you don't want to perpetuate that. So I'll show you why we shouldn't be using this. Some recent studies just in the past year and a half have really shown us that there's really no massive difference between men and women when it comes to presentation of coronary artery disease. I'll show you a table here, but don't worry about the numbers. I'll explain them to you, and I have a summary of the findings here on the right. So in this study here, published in one of the major cardiovascular journals a year and a half ago, they look at people coming in with a heart attack. And they say, how many people are coming in with a heart attack presenting with chest pain? So as you can see here, 87% of women and 89% of men had chest pain. So the lesson number one here is the far majority of men and women do have chest pain. So this whole business of women being atypical and you shouldn't expect chest pain in women, this is an old knowledge. It's been debunked. It's not the case. And women are just as likely as men to have chest pain. What seems to be different, however, between men and women, it's what's in the bottom here. Here they looked at how many additional symptoms on top of the chest pain the men and women have. So additional symptoms being some of these listed here: confusion, weakness, sweating, shortness of breath, palpitations, etc. And what they found is that women were more likely than men to have 3, 4, or more additional symptoms. So not only having chest pain, but having so many other things. And that's what seems to be the difference between men and women, and it really can cloud the judgment. It can cloud the judgment of the person experiencing the symptoms, because if they only have chest pain, they have a shorter differential list of what's going on. But if they have shortness of breath and confusion and sweating and fatigue, they may start to broaden and broaden this list of potential diagnoses that this person can have. So the patient experiencing this may actually not readily recognize that what they're experiencing is a heart attack. And similarly, at the level of the healthcare provider, if somebody comes to me to say they have, a whole lot of sweating and confusion and fatigue and also some chest pain, I may be thinking of other things other than heart attack. So this is what seems to be the main difference between men and women. Women have more additional symptoms as compared to men. And here's a very recent study. It hasn't even been published yet. It was just presented at the last European Society of Cardiology meeting in Paris last September, coincidentally the day I had my baby girl. So thanks to social media, I was able to keep track of what was going on. I actually did. Really this study was called the Herme Study, and it really helped debunk this myth of typical and atypical symptoms. This is what they do. So basically, the background for this is that, I'm a physician. When I went to medical school, I was taught to categorize a person's chest pain as typical angina. Angina is the medical term for chest pain as a result of coronary artery blockages. So I was told to classify as typical angina, atypical angina, or non-cardiac chest pain based on the characteristics of the pain and also the probability of the person. many men will fall in typical angina. A lot of women will find themselves in the atypical angina or non-cardiac chest pain just based on the nature of the symptoms and the risk. So this is what we learn in medical school. In this study, they took 637 patients that were referred for coronary angiogram, which is the gold standard invasive test to look at the heart arteries and look for blockages. And then they actually recorded the conversations between the physician and the patient, and they used artificial intelligence computers that were trained to then extract the language terms and analyze the language. Okay, so it's really advanced stuff. And the good thing about it is that computer has no bias, right? A human has bias, a computer does not have bias. So what the computer, after analyzing the language of the patient and the physician, what the computer found out is that 90% of men and women reported chest pain as a symptom. So again, confirming that the far majority of women does indeed present with chest pain, just like men. But interestingly, the computer is also identifying 9 other clusters of symptoms, other symptoms in addition to chest pain, and those were also identical between men and women. So the message from the Herme study is this: if you let a computer listen to the patient, the computer will think men and women are the same. If you let a human being listen to the patient, we all have our intrinsic biases. That's when we start to see things differently, right? So this is a really pragmatic and practice-changing and eye-opening study for many of us, because we are human beings. We cannot completely free ourselves from bias, but we should really try, because a computer cannot pick a woman and a man differently when they come for evaluation of heart disease. So again, there's no typical and atypical. Everybody seems to be the same. You really need to stop using these terms. The other thing that seems to be different for women is that women, more so than men, can have other chest pain triggers. Like I mentioned, the usual trigger is usually exercise. It's a pretty classic one. In the textbook will say that true angina is brought on by exertion and relieved by rest on nitroglycerin. But in real life, angina can be caused by emotional stress or anxiety, and this is more likely to occur in women. And I've seen my share of women who have had symptoms that are usually brought on by an anxiety or by a stressful condition or emotional situation. And it's usually reported that this is in their head, or this is because of their underlying depression and underlying anxiety. Sure enough, these psychiatric diagnoses can produce symptoms too, but the far majority of the time, it's not. It's really a trigger. And I will show you a science that shows, that demonstrates this. So this is, again, a study from about a year and a half ago, when they took 306 patients that had had a recent heart attack within the past year. And half of these patients were women. So lots of women in the study, which was great. At baseline, women had less severe blockages in the coronary arteries than men, and they had similar rates of revascularization, similar rates of stents and bypass surgery. So this is a baseline. Then what they did is a mental stress test. So if any of you here have been through a stress test, typically that includes exercise on the bike or on the treadmill, or medication to stress your heart, to then take pictures of the heart to see if the blood flow of the heart is impaired. And we can do that with the nuclear camera as shown here. We can actually measure the blood flow to the heart as a result of stress. What this study did differently is that they did a mental stress test instead of a physical or pharmacological stress test. Now, what was this mental stress test, you may wonder? So it's actually not that stressful. So they told people to say, you get up right now, you have 2 minutes to prepare a 5-minute talk about topic blah, 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 whatever it is. You know, it can be the Cold War or the history of Justin Trudeau, I don't know, something. And so that's enough to cause a little bit of distressing most of us, but I think you will agree that this is by far not even close to the stresses of your life, right? But even that tiny little bit of stress, just having to mentally prepare a talk to give in 5 minutes, and then they put the patients on the nuclear camera and actually quantify the blood flow to the heart, they found that women were 3 times more likely than men to experience impaired blood flow to the heart as a result of this very minor stress, right? So this is now science proving that this is not just in the women's heads. You know, this is actually a known trigger. I have lots of patients that have emotional triggers for chest pain, and I take them all very seriously because I know biologically that this can happen. The other point that I wanted to make today as to why heart attacks are not just like what you read about or learned about on TV is that not all heart attacks are created equal. As I was preparing this talk yesterday, my 3-year-old was sitting next to me and he was asking me what this was, so I was teaching him all about coronary angiograms and heart attacks. So I expect I'm going to quiz him today to make sure. He's a smart boy, so he should be able to pick this up. So he thought his father too. He said, "Dada, that's a heart attack." Anyway, so this is the classic heart attack that even my 3-year-old can recognize. So it's a severe or complete blockage of one or more what we call epicardial coronary arteries. When we use epicardial, it's just because they lie on the surface of the heart, and they are the big, chunky coronary arteries. The coronary arteries are like a tree. They have the big branches and they branch off into smaller branches. And with the angiogram, all you can see are the big branches. You cannot see the smaller branches. So these are the epicardial coronary arteries. And here's a very classic example. You don't have to be a cardiologist to see that this artery here is very plump and then narrows down to a trickle, 99%, 99% blockage, and then opens up again. Because we're injecting contrast dye inside the artery, we only see the inside, so we only see really the dent that this plaque has made into the lumen of the vessel. So this is very classic. If somebody comes to the cath lab with a heart attack or chest pain, with this, you don't need anybody, with trained eyes to recognize this. But not all heart attacks are created equal, as I said. Heart attacks or just chest pain can occur with, I put in quotes here, apparently normal or only mildly normal coronary arteries. And this particular phenomenon, which is having heart disease or coronary artery disease, angina, heart attacks with fairly normal coronary arteries, is more common in men than in women. So this person here with this angiogram was indeed having a heart attack, although look at these arteries, they are absolutely beautiful. There's nothing to even comment on. So with that, I'll introduce to you a few new terms. MINOCA, INOCA, and ANOCA, okay? I don't want you to remember this, I just wanted to understand the concept. MINOCA is a myocardial infarction, aka a heart attack, with non-obstructive coronary arteries, meaning the arteries look like this, wide open. INOCA is the same, but it's ischemia. So the person is not having a heart attack, but the stress test is showing poor blood flow to the heart, but they have an angiogram, and the angiogram looks fairly normal. And lastly, ANOCA is angina, just chest pain, and they have an angiogram, and the angiogram looks fairly normal. So these are now, I shouldn't say new because they're not that new, but definitely when I went to medical school, which is not too long ago despite Carrie's statement, I didn't know, nobody knew this. I certainly didn't, and nobody taught me these things. In fact, most of what I'm teaching you today, I did not know in medical school or residency either, because it was just not available knowledge. So these are new terms, and it can happen. So I'll show you here another study, and again, I'll guide you through the numbers so you can understand. In this is a meta-analysis where the authors did a humongous job of collecting data from 28 different papers to really characterize what is this MINOCA, what is this myocardial infarction with non-obstructive coronary arteries. They found that it occurs in 6 to 14% of all heart attacks. So it's actually not a small number. If you think about everybody having heart attack every day, up to 14% of these people will have a heart attack but will have a normal angiogram. And many of these people will say, you're on the angiogram, you'll be told your angiogram is normal, this is not a heart attack, goodbye. When in fact, they did have a heart attack. What they found when they compared patients with MINOCA with the patients with a regular heart attack with coronary artery blockages, they found that MINOCA patients were more likely to be younger, mean age of 59 as compared to 61. They were more likely to be women as compared to the regular heart attack, and they were less likely to have high cholesterol. So the typical characteristics here is a younger woman without a history of high cholesterol. That makes sense, right? So that they don't have high cholesterol, the arteries look fine, but they still had a heart attack. So this can happen much more so in women than in men. So having a coronary angiogram that is normal does not completely rule out the possibility of a heart attack or a coronary cause for chest pain. So what are some of the mechanisms for MINOCA, you may wonder? I'll show you a few things, and I'll guide you through these medical images because they're very, very interesting. This study, to me, was a landmark study from the group in New York in 2011, where they took women with MINOCA, so these women had heart attacks. they, based on ECG and blood work, they had an angiogram, but the angiogram looked normal. Then they went a step further and they put a catheter with an ultrasound inside the heart artery. That's called the intravascular ultrasound. So here are some examples and I'll explain to you. So if you look at this person here with MINOCA, they look at the coronary angiogram and there's really no lumps and bumps. This artery looks very smooth. So if you had stopped here, not done anything else, you would say you don't have a reason for a heart attack. But when they put the catheter inside, I'll show you here what we see. So these two pictures, what you're seeing in the middle is the actual catheter. So if you were to imagine the artery as a straw and you're looking down the barrel. In the middle here is the catheter itself. It's kind of stuck in the middle of the artery. What you see in the dark gray is blood, and the light gray is the plaque. So here, if you look at the pictures on the right, the authors have outlined this to make it easier to interpret. So if you look at this first person here, and by the way, all of these people have completely normal coronary arteries on the angiogram. This plaque here, if you look at the size of the artery, this plaque is only about 30–40% obstructive at most. So if you do a coronary angiogram, you would not say that this is causing a heart attack. But when they did the intravascular ultrasound, they found a break in the plaque. We call that a plaque rupture. Same here. This plaque here in light gray, shown here, is a very small plaque. This is maybe 10% obstructive. The angiogram would not tell you very much at all. But again, look at this. There's a fracture. There's a plaque rupture. Same thing here. A tiny little bit of plaque in the corner. Not enough to obstruct the lumen or the blood flow, but the plaque is unstable and has broken. Here's another one. I just wanted to show you the top one here, which is called plaque erosion. So in this particular study here, again, the coronary arteries look beautiful. When they did the intravascular ultrasound, there's a plaque here in the corner, like this crescentic shape here, which is about 10–20% obstructive at most. And there's a bite. It looks like somebody took a bite out of this plaque right here, and that's called a plaque erosion. So what we have learned is that in a lot of women with heart attack, but fairly normal angiograms, if you go a step further with intravascular ultrasound or even intravascular CT, you can see plaque disruption, and this has taught us a lot. So we definitely remember that as we see these cases of MINOCA. The other potential mechanism that can cause heart attack or chest pain or ischemia as a result, without involving the large coronaries, is the microvasculature. So here is a special type of angiogram that allows you to see the microvasculature. If you were doing just a conventional angiogram, you would stop seeing the artery right here, right here, right here, because you only see the large epicardial coronary arteries. But what you can see right here is that there is this incredible mesh of microvessels. Can you imagine? It's actually so abundant, and they actually have an important role in regulating the blood flow to the heart muscle as well, right? So what I like to explain to my patients is that our coronary tree is like a highway and the side roads. And the highway are the large epicardial coronary arteries, and the side roads are the little microvessels. So if you're trying to get home, meaning your blood trying to get to the heart muscle, you need to take the highway, but then at some point you need to take the exit to get to your house, right? So this is the conventional coronary artery disease, the conventional heart attack. When there's a blockage in the highway, in the big artery, there's a blockage there, then the blood cannot move forward. You're stuck in this traffic, you're not going to get home for a long time, if ever, right? So that's the conventional heart attack. But with microvascular disease, you could have a completely normal highway like this, and then you take your exit, and there's a bunch of cows. I don't know if you can see, but these are cows. There's a bunch of cows obstructing your way, and you're still not going to get home, even though when somebody is over in the helicopter giving the report for the radio, say, oh, wide open highway. That's the angiogram, right? Wide open highways. And then, your microvascular disease may be dysfunctional. And the microvasculature is actually very responsive to emotion and stress, right? These vessels have muscle in their wall, and this muscle controls the tone of the blood vessel opening and closing. So some, adrenaline will make them clamp down, for example. So I see a lot of my patients with presumed microvascular disease, because it's very difficult to diagnose, that they have a lot of emotional triggers for their symptoms, because the brain and the heart are very connected at the microvascular level. So that's another important thing to think about for causes of MINOCA, ANOCA, and INOCA, as I mentioned earlier. And this is important. This is a study from the group over in Los Angeles, it's called the Y study, the Women Ischemia Evaluation. So they actually look at women that had documented ischemia, poor blood flow to the heart, and 81% of them had either minimal or no coronary artery blockages whatsoever. They followed them up for almost 10 years after that angiogram. And what they found is that among the women that had no coronary artery blockage, completely normal, pristine coronaries, some of them suffered death, cardiovascular death, heart attack, stroke, heart failure, or hospitalization for chest pain, even though their arteries 10 years earlier was completely normal. So that goes to show about the role of the microvasculature, and that this is not a perfectly benign diagnosis just because your main arteries or your highways are not blocked. And what they also found in the study is that they were able to test. There are particular tests that can be done. They're very invasive, but you can actually pass a catheter inside the coronary arteries and inject some substances into the coronary arteries and measure the blood flow to test the reactivity of the blood vessels. So if one chooses to go that route to diagnose microvascular dysfunction, which they did for this study, they found that these women with normal coronary arteries but who had proven microvascular dysfunction on this test, they were much more likely to have a heart attack or death during that 10-year follow-up. So it's not a benign diagnosis, and we have to understand that it exists, and it can be a cause for symptoms and for events as well. And the last point I wanted to make about how not all heart attacks are created equal is regarding this pathological diagnosis called spontaneous coronary artery dissection. And we call it SCAD just for short, because this is too long of a name to pronounce all the time. So as you can see here, spontaneous coronary artery dissection, or SCAD, is a condition where the artery has no plaque, typically. There's no cholesterol plaque, it looks just fine. But one of the layers of the vessel wall, of the coronary wall, separates from the other two. We have 3 layers on our blood vessels, so one of the layers separates from the other 2, and it allows blood to seep into what we call this false lumen that now got created by the separation. And as you can imagine, as the blood seeps into this new false lumen, it starts to grow and clot, and then constrict the true lumen where the actual blood is going through to reach the heart muscle. And by constricting that, it impairs the blood flow to the heart muscle and can cause a heart attack as well. So again, I don't remember in medical school ever hearing about SCAD. In fact, I think most people really started hearing more and more about SCAD about 5 to 7 years ago, when the big registries from UBC and from the Mayo Clinic have actually started to publish a lot of data. So we're still learning a lot about this condition. And again, just to highlight here, this means a spontaneous separation of the coronary artery wall that is not iatrogenic. It means it's not a doctor who made it because they were poking around the artery, and it's not related to trauma. It's really, truly spontaneous. So what are the mechanisms of this SCAD pathology? So there are 2 theories, and I'll explain them to you, and I'll tell you which one I think is probably the correct one. So here's a normal artery wall with the 3 layers, the intima, the media, and the adventitia. One theory says that the inciting event, the promoting event for a SCAD, is a tear, and this tear then allows the blood to seep into the wall, and as this blood grows into the false lumen, constricts the true lumen and causes a blockage. The other theory is that the inciting event is actual direct bleeding into the arterial wall, and the tear may be a secondary event, almost like it's to vent out this false lumen and let the blood escape, because not every person with SCAD has a tear. So I believe that this is probably the correct. There has been studies most recently, as last year actually, showing that the patients that present with just bleeding into the wall without a tear actually do worse. So that means that they're not having a mechanism to vent out that pressure in the wall. So I believe that this is the correct mechanism, but we're still learning about it. And what are the characteristics of the SCAD patients? And this is why it fits into this talk here today, is because the far, far, far majority of SCAD patients are women. 90% of all SCAD patients are women, and the average age of the female SCAD patient is about 42 to 52 years old. I've seen people in their 20s, 30s, 40s, 50s, even 70s. The far majority of them, however, are going to be between 30 and 60 years old. So it's definitely not an age group where you would think a heart attack, right? It's usually a 30-some-year-old person, a 40-some-year-old woman with chest pain coming through the ER. They're not going to be triaged right away as a heart attack being the number one thing on people's minds. But SCAD actually changes this perspective a bit because it is actually a major cause of heart attack in younger women. And 20 to 25% of these cases of SCAD occur during the peripartum period. Typically in the first 4 weeks after having a baby, most commonly in the first week, but the bulk of them occur in the first week after having a baby. And that's how it was first described, actually. The very first description of a SCAD case was in a pregnant woman. And women that have SCAD during peripartum period actually have a more severe form of SCAD. They have SCAD in multiple vessels, they are more likely to die, they have a more severe form. The classic presentation is a young, healthy woman without any traditional risk factors. Many of them will be the picture of health, actually, and they will go on to have sudden onset of chest pain and a heart attack. So we should keep that in mind and tell our friends not to scare anybody, but just to be aware that young women can have a heart attack too, and if they do, SCAD should be at the top of our minds. And we know that there are some triggers for SCAD. I mentioned earlier the first 4 weeks postpartum being a particular trigger for some women. And interestingly, if you look at men and women with SCAD, what you see is that the far majority of women that develop a SCAD have an emotional trigger. And over my time as a cardiologist, I've collected so many histories from people about what kind of emotional trigger is enough to cause a SCAD. Sometimes it's massive, sometimes it's not that massive, but for her, it actually made a big difference. And men, on the other hand, they are more likely to have a physical trigger. The couple of male patients with SCAD that I follow, one had a SCAD when he went to the Tough Mudder race, like the Spartan races that they have to climb crazy things, and it's very physically demanding. And the other one was doing extreme biking, and the third one was doing extreme weightlifting on CrossFit. I shouldn't say CrossFit. It could be anything, any heavy lifting. I'm not being very politically correct today. Anyway, so women are more likely to have an emotional trigger, and men are more likely to have a physical trigger, which is very important because mental health care is an integral part of the care for women with SCAD after the event, because they are can you imagine if just by having an argument with somebody, you had a heart attack? So it's very difficult for these women to then move on and live their lives not worrying about that ever again. So we do have a very comprehensive psychological, mental, and sometimes even psychiatric follow-up for these women to make sure that they learn to cope and they find strategies to move on. So with that, I went here with some of these take-home points for you today. Remember that cardiovascular diseases are still the #1 killers of women in the world. In Canada, they're the #1 premature killers of women. In 2020, a heart attack is different than what I learned in medical school. And this is when I went to med school, 1999, 2004. And even in the early years of my residency in the United States, many of these things I told you today, we had no clue about. So we are learning more and more about heart attacks and heart attacks in women. Newer evidence from the past couple of years have shown us that heart attack and angina symptoms may actually not be that different between men and women. It's how we interpret them. We as a patient, and we as healthcare providers. And certainly mental stress can trigger ischemia, much more so in women than in men. So we actually do take that seriously as well. The last couple of take-home points for you is that heart attacks and angina can indeed occur even when the coronary arteries don't have a significant cholesterol plaque due to plaque erosion, microvascular dysfunction, or SCAD. And in a young woman with chest pain or heart attack, always SCAD should be at the top of everybody's mind. And the person, you can bring, many physicians actually have never heard of SCAD. A lot of our SCAD patients, when they go back to their family doctors, the family doctors have never heard of it. So it's also a part of your job to also educate your providers and let them know that young women can have a heart attack as a result of SCAD as well. So with that, I'll leave you here with this concept that we hope that you learned a few things today that you can share and start a conversation that eventually can save a woman's life. I also have a slide here to remind you of the Women's Heart Health Summit. As Natalie mentioned in the first talk, this is the largest conference in the world dedicated just to heart health, cardiovascular health, heart and brain health for women. We'll be here in our Ottawa, April 2nd and 3rd. It is open to all audiences, including people from the public. So you're welcome to register and join us. And here you can take a photo so you can remember this. So all the resources for you if you want to learn more. This is our website for the Women's Heart Health Center. This is our campaign website, wearedcanada.ca. The Twitter handles for the Women's Heart Health Center and Summit, our alliance, my own Twitter handle, as well as our Facebook and email if you want to stay on top of things. And if you choose to take a photo today and share on social media, these are the hashtags that we're using. Her Heart Matters, We're Red Canada. I'm not going to pronounce this because I don't speak French. But these are the hashtags that we're asking everybody to use. So with that, I'll finish here. I thank you very much for your attention and for your advocacy, and I'll be happy to take any questions at this time. Thanks. Was that on time?
Thank you, Dr. Coutinho. Actually, before we take questions, I'd like to invite Deborah St. Jean to the podium to tell you about her experience, and then we'll take questions for both Dr. Coutinho and Deborah.
Okay, well, thank you very much, Lisa. Dr. Coutinho, we've never met before, but I could relate to so many parts of your presentation. So my heart health journey started in late 2014. I had just finished I was finishing a very stressful period in my life. I was working for very long hours, like 80, 90-hour weeks for a 4-month period. And I was getting very little exercise and poor eating habits. So leading up to Christmas, I said to my boss, I said, I can't keep up this pace anymore. You know, we need to figure out what to do in the new year. And he agreed. I said, I'm taking my usual week off between Christmas and New Year's. And so I was very tired over that week. Got through Christmas with my family, although I remember thinking after Christmas dinner, I just wish everybody would go the F home, you know what I mean? So I decided after that, that's it. Now the rest of the week is for me. I'm going to rest and recover to go back to work after the new year. So December 29th, sorry, December 2014, then I started getting jaw pain in my right jaw. And I thought, well, I've got TMJ, you know, I can't know how to pronounce the long form, but so I started Googling, went to Dr. Google, I know you're not supposed to, and I right away thought it was that, and I started looking up how to do exercises on how to fix my jaw, you know, and that sort of thing. I figured it was stress related, for sure. I never even considered a thought of a heart attack. It didn't come up when I Googled it for some reason, and I never even crossed my mind. So it progressively got worse and stronger. And then by the afternoon of New Year's Eve, I started getting chest pains. And again, I don't know why, because I had no knowledge of heart disease. I didn't have any family history. I knew a lot about cancer, but not about heart disease in women. And it was my husband, you know, who said, well, maybe you're having a heart attack, because I think he got on the computer and started looking up stuff. But I was in denial, and I said, you know, this is preposterous. I've been a healthy, active, vibrant woman up until 4 months ago, and when I was stuck with this business issue, and I certainly didn't have time for a heart attack. I think a lot of us can relate to that. So I managed to get to sleep the night of New Year's Eve. You know, we didn't celebrate it or by any means. But I woke up about 3:30 in kind of a sweat, and I thought, okay, well, maybe I will go to the hospital. And I thought, this is a good time to go, because it won't be busy, and they'll have addressed all the people that came in from drunken accidents and so forth. So I said to my husband, fine, take me. And proceeded to have a bath and get cleaned up. So got to the hospital and they did an ECG right away. My husband was still parking the car. They started the blood work and very quickly diagnosed that I was having a myocardial infarction, you know, which of course I didn't even know really what that was. My husband, or they gave me more, they said, don't worry, we're going to give you something for pain. They gave me morphine and we're going to put you in an ambulance and send you to the University of Ottawa Heart Institute. So I was thinking, well, if I'm having a myocardial infarction, why aren't you, doing chest compressions on me or something like that? Like, this is how little I knew about heart disease at that time. So by 1:30 New Year's Day, I was back in my room here at the Heart Institute after having a new stent inserted to address a 95% blockage in my LAD. It was fantastic, what I went through. I was apologizing to all the team that had to be brought in on a holiday to do the surgery. I said, well, the procedure, I said, you guys should be home with your families, and typical, women type talk. And I felt really guilty. And I think the nurse said to me, she says, we don't see many type Bs in here. And she looked at me, she says, why are you here? She started, and I was telling her about my experience of working all these long hours. The unfortunate part is that I did damage some heart muscle at the bottom of my heart because I waited too long. I mean, I spent those 3 days with the jaw pain and did nothing. The good news is that the echocardiogram and subsequent PET scans show that my dead tissue in the bottom of the heart is not compromised too much. My ejection fraction is in the normal range, so that's good, and I certainly don't feel any effects, so I'm very happy about that. But I do realize now how dumb that was, not having the knowledge and not doing something sooner. I also feel I was very lucky because my risk factors were relatively few. I think Natalie talked about the 8 risk factors, and I guess my main ones were I was overweight. I had that brief period of inactivity, but I'd always been a fairly good exerciser. And my cholesterol was fine, no diabetes, no smoking, no family history. Although the cholesterol was just on the top side of normal, I should say, but my diet had been bad, and I was overweight, and it's the stress was a big factor as well. But just those 3 things combined was enough for me to have a heart attack. And looking back now, I think, wow, that was really just that right cocktail, and that's what did it for me. So like Dr. Coutinho said, like, stress has been a big factor in my life for various reasons, not just work-related. It's my personality, but I've also had a lot of family situations, caregiver stress, and ill family members. I have a daughter who's been diagnosed with schizophrenia recently, so I'm, dealing with a lot of stuff all the time. It seems like I can't seem to get away from it. But in 2018, I went through a period where I was under stress because my mother-in-law got ill suddenly, and she subsequently died. And I started getting intermittent jaw pain again, and it was just like I had before, and some chest pain, but it was quite minimal. But this time, I knew right away I did not wait, so I went for tests, and eventually my cardiologist did another angiogram, and they found a 70% blockage in the same artery, just further up or down, I can't remember. So now I have a second stent. But at least I knew enough to advocate for myself. I wasn't, I did follow the channels, went to my family doctor, and then referred me back to my cardiologist. But what I learned from that is that I need to make my needs a priority. And I know that stresses in life, we can't control everything. We can't control some of the things we can. There's a lot of risk factors we can. So how I react to my stress is really what I focus on. I manage through cognitive behavioral therapy, mindfulness, exercise is a big part. Since my heart attack, I think my exercise has been quite good. Eating habits could be better because I am a stress eater, so I do look to eat my feelings and for comfort, so I need to watch that. And I want to have that healthy relationship with food. I like to try and think of it like I live to eat, or no, I eat to live, not live to eat, right? So I just need it for nourishment. And what I focus on is, I think, as Lisa said in my bio, is I like to focus on the things that bring me joy and try to fill my tank up, and rather than always running on empty. So that's what keeps me going through those periods. I also find that humor goes a long way, so I'd like to share with you a funny anecdote. As I said, my mother-in-law got ill last year, and I had jaw pain. Actually, yeah, the previous time when I had the stent, sorry, was not from my mother-in-law, it was something else, but I recognized it. So then when my mother-in-law got ill and I had jaw pain again, I thought, okay, now I know, no more long in denial. I thought, it's my heart right away, because it was a stressful time. But the weird thing is this time, instead of being in this side of my jaw, and it used to go exactly from my ear to my chin, both the first and second time, the third time, it was just on this side, and it kind of moved around my face. And I thought, well, maybe it's just a different artery, that's why it's now on the left side. So I had followed my usual thing. I went to the doctor and had tests done. It turned out it was a tooth infection. It wasn't my heart. So I had to have a root canal, but I can laugh about it now because, it's like, oh no, I know now what's wrong with me. But, the step, when I came to emergency, I remember I'd done some stuff, and finally it just getting worse and worse. And I'd even been to my dentist, and she didn't even recognize it. Like, she put cold on me, and we couldn't reproduce the pain. So I did end up in emergency, and the doctors at the Civic were wonderful, and they said to me, don't worry, you did the right thing coming in. They did all the tests, the blood work, didn't find anything. So once I heard that expert opinion, I still advocate for myself, but I said, okay, there's something weird here. So then I went back to my dentist the second time, and this time she really gave me the cold test, and I practically went through the roof, and we figured out that was the problem. So I just wanted to say that, say for women, pain fades with memory. And I kind of think that's true, because I sort of feel like my tooth infection actually hurt more than my heart attack, but that was really recent. So I'd like to thank you for letting me share my story with you today. Thank you.
Thank you, Deborah. Thanks so much for that important perspective, real-world story. Dr. Coutinho, we'll invite you back up, and I have a microphone. I'll run around and take some questions. Our food demo's at 11:30, so we have, let's say, 5, 10, 15 minutes for questions. Coffee and tea is being replenished, and then food demo at 11:30. First question here.
It's not so much a question, but you may comment on it, is the difference between the EKG machines or the paramedics come with and the one at the hospital, because not all of us, some of us may live alone and we have to call for an ambulance with paramedics, and they hook you up and they may see nothing and may convince you, we don't see anything, and try to downplay any need to go to the hospital.
It's not the machine. The machines are actually the same. So for the ECG alone, obviously there are so many other things we can do here in the hospital that the paramedics cannot do in their ambulance. But the ECG is fine, actually, and it can see the same things. If you're having a heart attack, not every heart attack, however, can be seen in the ECG. There are a couple of types of heart attacks that can be easily seen in the ECG. Those are easy to recognize. And a number of people can have a heart attack with a completely normal ECG. So if they didn't see in the paramedics, in the paramedic ambulance, they may not see it in the hospital. Or it could be that something developed in between. But the technology is the same, actually, for that particular aspect, which is the ECG. But remember, not everybody will have abnormal ECG in the face of a heart attack.
I was told something different by a different doctor about there's a difference in the sensitivity of EKG.
Yeah, they may have just the rhythm strips, which, is those long ones that run and run and run. Have you seen those? It's just a skinny rhythm strip. And they can actually run different leads, as opposed to us here, we usually just hook you up and they get one page with all of the 12 leads of the ECG in the one thing. But actually the paramedics can diagnose. And in fact, I believe just this week, the Minister of Health actually gave some more latitude to the practice of the paramedics. And what I trained at the Mayo Clinic over in the United States, there was actually so much confidence in the ECG done by the paramedics, and because of that concept that I told you earlier, that the time is muscle, that in Rochester, Minnesota, which is where the Mayo Clinic is, the paramedics could actually activate the heart attack protocol straight from their ambulance. Because typically what happens is the paramedics will see something, they will bring to the hospital, the patient would then see a doctor at the emergency department, and if the doctor sees a particular type of ECG that is considered what we call STEMI, that you have to be whisked to the cath lab immediately, then the doctor will activate. But because everybody's always trying to save time and get people in as much as possible, actually in Rochester, Minnesota, the paramedics were able to activate that protocol already from the ambulance. So the time the patient arrived at the hospital, they arrived straight into the cath lab. And then at that time, there could be a stop. If somebody found, oh no, this is wrong, it was actually preferred to stop it in the cath lab and realize they were wrong than to actually delay somebody from getting into treatment quickly. So, I would be fairly confident in the ECG of the paramedics. And again, not all ECGs will show heart attacks though.
Well, I would just caution from my own experience that was not the case with me. Mm-hmm. Two sets of paramedics dismissed it, and I was having a study.
Okay, so
a couple of days went by because I thought, well, I'm the one being overreacting. So I agreed with them not to go to the hospital. Mm-hmm. That was a mistake on my part.
Yeah.
Make sure that if you feel that you need to go to the hospital, go to the hospital.
That is correct.
I learned that the hard way.
Mm-hmm. And just one more comment to this. STEMI, some of them are obvious, like you don't even have to have trained eyes to realize something's wrong. Some of them are minimal, and some of them, depending if it's in the back wall of the heart, it's called the posterior wall, those can be very hard to find. So sometimes it's actually the eyes of the person too that are looking at the ECG and looking at very subtle findings can make a difference as well. But you're absolutely right. It doesn't matter who it is that is telling you not to worry. If you're still worried, there's always a good reason to get it checked. Absolutely. Mm-hmm. Yes.
Yes. You mentioned that the angiogram can appear normal, but you're still having a heart attack.
Yeah.
So I'm wondering how real is it to think that the doctor, if your angiogram is normal, mm-hmm. are they going to continue with the other tests that you mentioned, ultrasound and CT and whatever? Or are they just going to say your angiogram is normal and you don't have a heart condition, you can go home? I'm just wondering what the odds are.
I wish the answer was, don't worry, every doctor knows about this, they are going to treat you as you should. That's not the truth. There is definitely a growing body of knowledge, and I think more and more physicians are becoming aware of it. Definitely here at the Heart Institute, people are very well versed in this. We keep talking about this, especially in women. But it is not true to say that every doctor will know about this. So many times people will say normal angiogram, you can go home. But what we do know about MINOCA, as I explained, is that even in the presence of normal or apparently normal coronary arteries, we still treat them the same way. We still give them aspirin, we still give them blood thinners for a little period of time, we still put them on cholesterol medicine because we know from other studies that even a number of people with MINOCA do have cholesterol plaques here and there, even if they're not obstructive. So we actually treat people very aggressively, and also knowing that people with MINOCA are more likely to come back with another heart attack, probably because they weren't treated right in the first place. So we do treat people actually quite comprehensively, not with stents, but with medical therapy, rehabilitation, and so forth. But it's always good that everybody here knows about this, just in case your doctor or your nurse have never heard of it, you can bring that to their attention as well. There's definitely a growing knowledge, but it's not widespread knowledge yet, unfortunately. And this is the summit next, in a couple of months, is one of the things we're going to talk about, because we're really trying to educate more and more providers about this. Mm-hmm.
I wanted to ask you about the MINOCA. So if a person has an angiogram, a standard one, and there's zero plaque on the arteries, and as in my case, I had an AVR due to a bicuspid, mm-hmm. and I had zero plaque on my arteries. Until you spoke today, I thought, good, I'm out of the woods in terms of mm-hmm. propensity for blockage. From an imaging perspective, why don't they just give the more detailed angiogram to begin with?
So a couple of things. The far majority of people with clean, pristine coronary arteries will be just fine, right? I don't want to scare anybody that just because you had an angiogram because it's a necessity prior to having a valve replacement.
Right.
And your arteries were labeled as being normal. The far majority of people in this situation will be just fine, okay? It's the ones that are coming back with chest pain despite a normal coronary angiogram that we worry about. So that's just one thing I wanted to clarify. Far majority of people will be fine. Two, the two reasons why we don't do this test more extensive, like the intravascular ultrasound. One, it is not without risk. When I was again at the Mayo Clinic, we did quite a few of these tests that we have to go inside the artery to either test for microvascular dysfunction or intravascular ultrasound. And every time you put a catheter inside the artery, a conventional angiogram doesn't go inside. It hooks the ostium of the artery and injects the dye from there, but doesn't go in. Every time you put the catheter in, you can tear that vessel. So you are incurring a higher risk for a patient. Let's say you came in with chest pain because you have a gastric ulcer, let's say, but you ended up having an angiogram and your arteries are normal. Now somebody just tore your artery because they went in with the catheter. So there's a small risk there that we are not willing to incur in everybody that comes in. So they do use the intravascular ultrasound and also intravascular CT if the physician thinks that it needs to be clarified. So sometimes they will see a plaque that is not perfectly obstructive, or sometimes there's a long plaque and they want to have a better insight about that plaque, then they will go in and do it. The other reason is that government doesn't pay for it. So we have our own budget here at the Heart Institute that we buy some of these catheters for CT and ultrasound, and we use them as needed based on the criteria I just mentioned, but this is not covered either. So there are a couple of reasons there. But I would definitely not advocate for that to be done for everyone because of the risk of tearing the artery. So you have to select the right cases for it. And don't worry about your angiogram. Yeah.
Any other questions? Yep.
Excuse me, I would like to give a small thing. At age of 12, myself, I was in school, and they've been pulled out from the school saying, quote unquote, your heart is inflated and you may die soon.
Your heart is a what, sorry?
Inflated?
Oh.
That's the term they use.
Inflated.
At the time. This is about maybe 58 years old, 58 years away, you know. They put me out of school, they damaged my ear, and after 4 or 5 months of testing, they said, okay, you are normal. And since that time, I never heard back from my heart. Until about 3 years ago, I came here for a chest. They tested and they say, you are okay. Last December, I was in Toronto traveling, and suddenly I feel something, and they put a stent. What your presentation present here, you discover more now about the heart. And from what I understand, we are supposed to know, at least when we talk to the doctor, what is maybe we can suggest more tests and so on. I don't think that everybody knows that.
Yeah, it's a partnership for sure. A couple of comments. 58 years ago, we didn't have echocardiogram. So the diagnosis of enlarged heart, I think that's what you were getting to, were based on x-rays and physical exam, which may not necessarily be as accurate as we have nowadays with CTs and CTs and MRIs and echocardiograms. Echocardiogram is only 40 years old. So maybe at that time somebody had an impression that wasn't true because we didn't have the diagnostic abilities that we have today. I'm just speculating. And you mentioned, and inflated heart, the large heart, is not something that it's going to trigger people to necessarily think you're having a heart attack. So you can dissociate these things. If you're having chest pain, regardless of what you heard about the size of your heart, you'd be evaluated for that regardless. And this partnership between patient and physician is very important. At the end of the day, the physicians, the nurses, whoever is the healthcare provider you're seeing, this is a person who has studied a long time. I can tell you myself, I think I lost count. I think it was 14 or 15 years of medical training before I ever, took a job. So it's a lot of training that these people go through, and they have good insights, but nobody is perfect. There are knowledge gaps that one person may have and the other one may not. And that's when this partnership comes in, saying, listen, I learned recently about this and this. What do you think about it? And when patients tell me things I don't know, I make it upon myself to ask a colleague who may know or to look into this, into some detail. So that partnership is really important, as you mentioned. I think her in the back there, she had the hand for a long, long time. And then, how much more time do we have, Carrie?
I just want to say that I think you're a real treasure, and we're really lucky to have you here at the Heart Institute.
Thank you. Thank you. That's sweet. Thank you.
My question is, there's only one of you, and I know that you probably have a good team, but I was wondering if you've considered having ambassadors go out to maybe even some of the smaller communities and talk about women in heart disease. Not women who have had heart attacks, but just to create better awareness in the communities. I'm close to Carp and Almont, and I would, if a program like that ever started up, I would be more than happy to go to a public library and talk about it, because I talk to people so often about heart disease, and there are so many women that I know that don't really understand what's going on with their bodies, and I think there would be an interest in it in the community.
You may raise a great point, is because we have all of these resources here at the Heart Institute, but not everybody can come to us. And this is why we're developing resources that can be actually taken up via the internet. So the answer for you, if you go to yourheart.ca website, which is our Women's Heart Health Center website, look for the link for the advocacy toolkit, community advocate toolkit. So this is, have you taken it already? So basically what you can do, we did it precisely for this reason. Great, thank you. It's because we were having people like you saying, listen, I know these things now. I feel very passionate about it. I want to talk to others about it and raise awareness. And people were Googling things. I'm saying Google again. They were, you know what I mean? They were looking for things. They were trying to find images and put things together. So we made it easy for you. This course has it is a course and a toolkit. And the course has two parts. One is about how to tell your story, how to speak in public, how to set up your community event, and it gives you all the resources you need for that. And the second piece is actually knowledge, some facts that you need to know if you want to advocate. And then you take that course, and then you get access to the toolkit, and then you are a community advocate, and you can actually organize these events, and we help you do that. So just make sure you go to our website, and we would love to have you be one of our advocates. Thank you. You're welcome. I have given lots of talks. Basically, when they invite me, I go. So I have given lots of talks to lots of different practices, from family med to endocrinology to obstetricians, there's something called, I think it's called Canadian Women in Medicine group. I've given the talk. So I've done quite a bit of that based on invitation. And really our summit is our main educational piece that's coming up now in April. And the Heart Institute also offers some what we call CME, continuous medical education. So just in 2019, the main program for the community was on women's heart health. So we do that. Probably we certainly can do more. We should do more, but we are quite active in the community. Yeah, and they can invite us, and we can talk. And Natalie can go talk about cardio-prevent. I can go talk about the things that I talk about all the time. What else can we talk? Yeah, Nadine can go talk about women at heart. We have lots of things. If they invite us, we are happy. We don't charge, and we're just happy to pass the information. Yes.
What is an enlarged heart, and what are the effects of that?
So an enlarged heart typically means that the heart has become enlarged and typically weak as well. And that can be for a variety of reasons. The most common cause for an enlarged weak heart is actually coronary artery disease, blockages in the heart arteries. Basically, that would be a person who has had a number of heart attacks in the past, didn't get treated right away, and then the heart muscle has died and the heart has become weak and large. That's the most common reason to have an enlarged heart, although it's not the only reason to have an enlarged heart. There are some genetic conditions that can run in families that can get people to have enlarged weak hearts. Sometimes there are viral infections. We catch the flu or a cold, and sometimes our bodies react with the virus in a funny way and attack the hearts, and it causes inflammation of the heart called myocarditis. That can cause an enlarged heart as well. So just a few examples. But the most common cause for an enlarged weak heart is coronary artery disease. The effects of that, as you mentioned, some people can have no symptoms at all. or they can have heart failure symptoms because the heart is enlarged and not as strong and not as efficient. The people can feel short of breath with activities that didn't make them short of breath before, or even at rest. The legs can swell because they're building up fluid. The doctor looks here in the neck veins, they can see high pressure in the veins. Sometimes it's hard to lay flat at night and you wake up feeling short of breath because you cannot lay flat because of filling up the lungs with water. So some of these are the symptoms of heart failure that can result from having an enlarged heart. Although some patients we have no symptoms. You're welcome.
Okay, we have time for one more question, and it's right here. And just before we do, this talk has been recorded. It'll be available on our website. It'll also be posted on social media. So have a look out for that. Thank you so much to our speakers. I'll thank you now. At 11:30, our food demo is taking place here. Those recipes will all be available during lunch.
And we actually have printouts of the recipes. So there's amazing, very heart-healthy salads, 3 to choose from. And the menus and the recipes will be available.
And to hear more about our Community Advocate Toolkit, that's our 2 o'clock talk today.
Yes.
So our last question.
There you go.
Thank you. I'll keep it short. I'm showing my ignorance here. I was always under the impression you had a heart attack and that's it. But from what I'm gathering from what you're saying and the people here, you've had a heart attack and it's ongoing for a few days?
This is an incredibly good point, and it's not ignorant at all, and I'm very glad that you raised it, because the far majority of people, men and women, think that a heart attack is an episode. Like you've had a heart attack, it's a page of the book of your life, you can now turn and you move on. And heart disease is a chronic disease. It's a chronic disease. So you have a heart attack today, now for the rest of your life, you need to live with this. Even if your heart was fixed and you have no damage, you now have heart disease, and that's a chronic condition, and you have to take care of your body, your risk factors, your exercise, your rehabilitation. So it's not an episode. So I'm very glad that you brought this point. And in terms of the actual presentation, which I think is what you were getting to there, it can be quite abrupt, or sometimes people can get little warnings. It's much easier to recognize in hindsight. Like in hindsight, I had a heart attack on Thursday, but on Wednesday and Tuesday, I was feeling this and this and this and that leading up to it. So we can.
So could you have had a heart attack and not know?
Yes, many people can have a heart attack and not know. Very common, I shouldn't say very commonly, but more commonly than not, more commonly than non-diabetics, the diabetics can have a heart attack and not know. Because just like diabetics can have neuropathy of the hands and feet. Have you heard about that? That they lose sensation in the hands and feet. They can have neuropathy of the heart too, so they lose some of the pain sensation and the innervation of the heart. So diabetics are more likely than non-diabetics, for example, to have a heart attack and not know. Or sometimes a person can have a heart attack with some of these unusual symptoms and never connect 2 and 2 and not realize that that was a heart attack. Like the patient I mentioned with the neck pain, thought she had Hodgkin's lymphoma. She never knew she had a heart attack until she gave her doctor heart failure, and in hindsight, the diagnosis was made. So it can happen.
What if you have diabetes, but you've got your A1C down, and you still have the silent problem, possibly? So the problem with neuropathy is dependent on duration of diabetes and control of diabetes. So long-standing uncontrolled diabetes is much more likely to lead a person with a problem with the nerves, whether it's in the hand, the feet, the heart, etc. If a person has had a short duration of diabetes, it was just diagnosed 5 years ago, and or is very well controlled, that's much less likely to happen. Okay, thank you so much.